Good afternoon. Welcome to Grand Rounds today. If you could find time to respond to the program evaluation that would or will be emailed out, we'd really appreciate that. Today I have the pleasure of introducing Dr. Michael Kitchell. For many of you, Dr. Kitchell doesn't really need any introduction. He is a board-certified neurologist and also is the medical director for the Inpatient Rehabilitation Unit here at Mary Greeley. And we're very pleased that he has graciously accepted our invitation today to update us on the causes and prevention of falls. And please join me in virtually welcoming Dr. Kitchell.
Thanks. I brought my face mask, and I'll be talking about prevention of the injuries, and I hope all of you who are out there in public are actually using your masks to also prevent injuries from a bad virus. And I can't wait, like most of you, to get back to our normal lifestyle where we can actually meet and have our faces available to show our emotions and our expressions. So today I'm going to be talking about both some causes and prevention of falls. Like Dr. Hallberg said, I'm not only a neurologist, I'm actually director of the rehab program here too. And in the inpatient unit here at Mary Greeley, I happen to see a lot of victims of falls. I see a lot of people who have a hip injury or other broken bones, and sometimes some head injuries as well. So this is why I wanted to present this topic today. I'm trying to keep the number of people who have to be cared for in the hospital down by avoiding these falls. So I think most of you know that falling is a pretty common occurrence in the elderly, but nationwide the number of falls means that every 20 minutes an older adult dies from a fall. And then every 13 seconds, an older adult is treated in the emergency department for a fall-related injury. So that tells you that, unfortunately, not too many falls lead to death, but obviously we want to prevent any type of fall if we can. So for the United States, about 29% of 65 and older Americans fell last year, and 45% of them actually had 2 or more falls. And if you want to know how many of those falls actually lead to a significant injury where they needed treatment or they had to decrease their activity, about 37% of those led to an injury that had to be treated or they had to avoid some activity because of the fall. And I always tell people that there's no good thing that happens when you fall. And so 800,000 admissions per year are due to falling and the injuries that result. The head injuries and hip fractures are the most common injuries that are seen. The bad statistic here, too, is that 20% of the elderly who had a hip fracture actually died within a year, not necessarily because of the hip fracture, but it added to their disability and their need to stay in a nursing home. And we know right now that with the COVID virus, being in a nursing home is definitely a danger. About 33% of the deaths in Iowa from the COVID virus have occurred in the elderly in nursing homes. The number of people who are dying from fall-related injury is also increasing. In 2000, there were 8,600 deaths that occurred, or deaths that occurred from falling. And in 2015, which was the latest survey, 33,000 deaths occurred from falling. And it's estimated by 10 years from now, 49 million Americans will suffer a fall. And the reason I think that some of the increase has occurred is that more patients are on anticoagulants because of atrial fibrillation or some other cause. But when they fall, they can have a brain injury and bleeding inside the brain, or they may have other bleeds that can lead to serious complications. Now, the cost of health care is on everybody's mind, and that was present even before the COVID virus. But the amount of taxpayer and insurance money that's spent on injuries is really staggering. It's $67 billion a year are spent for treating injuries due to these falls. And 6% of all Medicare dollars are actually spent to treat those fall injuries. And then Medicaid likewise has 8% of their payments are for fall injuries, and a lot of those are due to nursing home costs because, as you know, Medicaid actually pays for much of the nursing home care. So I think most people don't realize it, but one person with a hip fracture is going to cost the system, either the insurance company or Medicare, $50,000 for that hip fracture recovery. And the average stay for a Medicare patient who has a hip fracture is 5 or 6 days in the hospital, and then an additional 12 to 20 days of inpatient care, either in a rehab facility like Mary Greeley or in a skilled care facility. But 25% of the elderly who have a hip fracture actually will spend a year or more in nursing homes after a hip fracture. And as I mentioned, there are 20% of those patients who actually die within a year. As a rehab director here at Mary Greeley, I see a lot of other fractures that end up in the hospital. And believe it or not, an ankle fracture for an elderly person might lead to a hospital stay. Obviously, leg fractures do, and pelvic fractures do. There are actually some people who fracture their humerus, or I've had patients who've fallen forward and broke both of their wrists. Those patients also needed to be hospitalized for a period of time because they couldn't manage on their own. And as most of you know, osteoporosis or osteopenia patients are at higher risk for fractures. So I think you all know, as the title of my talk, it's obviously a lot better to prevent falls and injuries. And treatment is obviously necessary, but the cost of the fall is a real significant impact to the patient, but also the cost, as I said, $50,000 for a hip fracture and repair is a lot of money for the taxpayers or the insurance company who's covering the group that is insured. Now, quality measurement over the last 20 years has given physicians incentives to do higher quality care of their patients, and a lot of measures are used to try to improve the quality of care. Right now, Medicare accountable care organizations and the quality payment programs both measure these fall risk assessments. In other words, physicians or providers will do a risk assessment of people, and we do report those, and we also, at McFarland Clinic, as part of our fall risk assessment, we automatically refer those patients to either getting some help with frailty or with some physical therapy to try to avoid more falls. We have a quality measure dashboard both at McFarland Clinic and at Mary Greeley, and both of these measure dashboards do consider the fall risk assessment or keeping track of falls as a very important measure. As I said, Mary Greeley tracks falls in the hospital as part of their quality and safety measures, and we obviously want to keep those numbers as low as we possibly can. We also track if they have falls with injury or whether they had a fall that didn't result in any major injury. Unfortunately, most of the falls at Mary Greeley do not result in any harm to the patients. As I mentioned, accountable care organizations, an accountable care organization is a group of physicians and sometimes hospitals that sign a contract with an insurance company or Medicare to focus on reducing the costs of care and improving the quality and outcomes of care for the patients. These accountable care organizations actually are rewarded by sharing some of the savings by reducing the costs of the total amount spent on a group of patients. For example, Medicare patients, at McFarland Clinic, we have about 17,000 Medicare patients who we take care of, and Medicare keeps track of how much is spent on that total population of patients. And McFarland Clinic has been successful last year in bending the cost curve down, so we actually did receive some shared savings from Medicare. We also at McFarland Clinic have received some shared savings from Wellmark too. And so by avoiding costly care, such as avoiding the cost of a hip fracture or a brain injury from falling, the physicians who do impact the lives of their patients by not having them fall, they do get some incentives and rewards. Now, as I said, Mary Greeley does keep track of the falls for inpatients, and it is exceedingly hard to prevent these because we want the patients to be up and out of bed for parts of the day, and we want the patients to ask for the nurse's help if they need to get to the bathroom or get up and around. But unfortunately, most of our patients that are in the hospital are either weak or confused or impulsive. And unfortunately, many of those patients don't wait for help. And so the strategies that are used include a robot which can pick up the movement of the patient and actually tell the patient, please sit back down. And other alarms like movement detectors or pressure pads also can tell the nursing staff or others around the patient that the patient has gotten up from the bed or gotten up from a chair. Sometimes, though, it's so serious in the patients who are really impulsive and confused that we have to have a person actually sitting outside or at the doorway to watch that patient so they don't get up and fall. So it's actually fairly costly, too, for the hospital to make certain that our patients don't fall. Now, I'm going to talk a lot today about conditions that increase the risk of falls. And I can tell you that in a lot of younger patients who fall, it's because they do things too quickly. They try to get up on a ladder or they get up on a hike and fall. But older people, they don't necessarily all go up on ladders or go hiking and slip off of a cliff. It's pretty easy just for them to fall by not watching where they're going or other factors that I'll talk about later. One of the issues that I want to spend a little time on today is called frailty, and I've got a slide about that next, but it is a very common cause of patients falling. They are at high risk of falling. The other thing that I'll talk a little bit more about today is gait disorders. That is, people who have some equilibrium or balance difficulties that affect their ability to move their feet and legs to keep their balance. I'm going to talk a little bit more today about Parkinson's disease too, which is a fairly common disorder, and it is also a frequent cause for some patients to fall. There are a number of other neurologic diseases that I'll be talking about too. And one condition that is often overlooked by a lot of physicians and providers is a drop in blood pressure. Sometimes older patients don't actually sense the fact that they're woozy, lightheaded, or dizzy. But sometimes because of the medicine that they're taking or their condition, they do have a drop in their blood pressure when they stand up or they've been standing for a while and they don't realize it, but their blood pressure drops too low. So then they will simply fall because of that low blood pressure when they're standing. I'll also be talking a little bit more about vertigo. But I want to emphasize that just because somebody says they are dizzy, that doesn't necessarily mean that they have equilibrium or balance trouble, and it doesn't actually mean that they're likely to fall. I'll talk about that, though, as I said. Now, gait disorders are very common as we all get older. In fact, by age 85, about half of the population will need a cane or a walker. So by age 85, hopefully everybody is either going to be thinking about getting some help or live in a place where they have some assistance. The workup of a patient who has a gait disorder is to figure out why the patient has this balance difficulty or equilibrium problem. These patients often have fallen once or twice or more even before they get this workup. And some of these patients do complain of dizziness, but it's not necessarily vertigo. It's lightheadedness in some people, it's a wooziness in others. Some people, it's actually a little confusion or concentration difficulty. Patients who have a dementia actually have a high risk of falling too. So the examination that we do for a person who has a gait problem or equilibrium problem is we watch them walk, and obviously we want to see how they swing their arms, we want to see their stride length, we want to see how well they turn. We also do what's called the tandem gait. But as I said, as we all get older, the tandem gait, which is putting your heel in front of your toe and walking like you're walking a drunk driver's straight line. As we all get older, especially those of us over 70 or 80, it's hard for even a normal person to do a perfectly normal tandem gait. The Romberg test is a test where the patient is standing and then you ask them to close their eyes. And if they have trouble maintaining their balance, that's actually more of a sign that they have some proprioceptive problem. That is, they have some position sense difficulty to keep their balance. They might be able to balance quite well with their eyes open, but the Romberg is positive if when they close their eyes, they lose their balance. The other part of the exam that I mentioned earlier that I don't want to be overlooked is to check the patients for an orthostatic blood pressure drop. A lot of nurses are in a hurry and they've got to get to the next patient. And so they just do the blood pressure sitting. But when the patient has a symptom of dizziness, lightheadedness, equilibrium, or balance difficulty, please have the nurse check the blood pressure sitting and standing. If the blood pressure drops about 15 or 20 points, either diastolic or systolic, it's probably significant. As I said too, the proprioception is a significant problem. We do have some diabetics who have a neuropathy, and that sensory loss in their feet does affect their balance. Some patients with vitamin B12 deficiency also have some loss of proprioception, and those patients have a gait or a balance problem too. So the workup for patients who have a gait disorder is always an MRI scan for the younger patients. And in older patients, the more rapid the onset, the more likely a CAT scan or an MRI scan will be necessary to do a full workup on those patients. And as neurologists, we actually see a lot of people who have a fairly normal-looking MRI scan and might just show some white matter changes that are nonspecific. But if the workup is negative, then we would call that person who has a gait or a balance problem as a gait disorder. A gait disorder is as much of a diagnosis as Parkinson's disease is. So we do sometimes end up as the final diagnosis as a gait disorder. And as I said, half the patients 85 years or older do have some type of gait difficulty. Now, Parkinson's disease is a common diagnosis that I treat. And I think most people know that Parkinson's disease patients have a tremor, rigidity, that's some increased muscle tone, and bradykinesia, that means slowness. But the fourth symptom of Parkinson's disease is often the hardest one to treat, and that is a lot of patients with Parkinson's disease have an abnormal gait. That is, their walking is slow, and they might not swing their arms. They might have trouble turning. They might tend to turn in a shuffling type of manner. They have what's called postural instability. Their posture is not very steady, and they can tip over easily. And as I said, that's one of the hardest parts of Parkinson's disease to treat, is the postural instability. Many people who've had Parkinson's disease for 15 or 20 years do have significant problems with their gait and falling. The typical Parkinson's patient, when it's getting a little more serious, tends to shuffle. They have trouble getting up out of a chair, and they sometimes have trouble initiating their gait. They sometimes have a freezing type of complaint where they just can't pick up their feet and get the feet to go. So that's called freezing. That can be a transient type symptom, or it can be something that's persistent too. As I said, they do have a loss of arm swing. That's called associated movement. I think most of you, when you look at an athlete running or jumping, you know that they use their arms a lot to do that. And so that's a good example of how athletes have that associated movement and have that dexterity, that agility that people with Parkinson's disease are missing. A lot of people with Parkinson's disease have a tendency to lean. Some of it's leaning forward, like a kyphotic posture, but even some people with Parkinson's lean to one side. They generally have a stiffer posture, both with their neck and their body. They tend to turn and block. That means as a block. When we check a person with Parkinson's disease, we check for alternating motion rate testing, and we check for rigidity in the extremities and watch how their trunk is moving when they turn, especially when they are walking and turning. The other signs that can help with diagnosis of Parkinson's disease include facial masking. That means a loss of facial expressivity and blinking rate. Some people with Parkinson's disease have a soft or a hoarse type of voice, and they sometimes speak rather rapidly but don't articulate very well. It's called a hypokinetic dysarthria. And some people with Parkinson's disease have a little trouble swallowing, and they tend to drool because they don't swallow often enough to keep the saliva from clearing. So I'm going to talk about frailty next because this is really one of the most common causes of falling. And frailty is defined as the condition of being weak and delicate. And frailty is not always related to aging. Those people who are motivated and active might be able to avoid having frailty for most of their lives. So age is a risk factor, but it's not a certainty that just because you've gotten older that you're going to get frail. Now, when you look at the number of people in the 65 to 74-year-old age group, 27% reported falls, but people who are over age 85, even though they already know they have some difficulty with their balance, 37% reported falls. And as I mentioned earlier, those people who are elderly who fall, 37% of those patients have to have some treatment or restriction in activity. In other words, those falls are very serious over a third of the time. So what we try to do is avoid frailty, and if the person is motivated, we are going to try to get them into an exercise program, and I'll talk a little bit more about those ways of treating both frailty and avoiding falling. One common misconception is that arthritis is causing someone's problem with their walking. And it certainly limits their walking, but the gait and balance difficulties are not due to arthritis, though the arthritis may cause them to be less active and then lead to frailty. So, like I say, arthritis may limit someone's walking, but it should not affect their gait or balance unless that arthritis leads to frailty. Medications are another major risk factor for falls, and just like I mentioned, the orthostatic hypotension, this is something that needs to be reviewed by every physician. We do have medication reconciliation for every patient who comes to our clinic, and this is very important to look at because as we all get older, we get more and more susceptible to these side effects of medications. It's been estimated that having someone on a sleep medication, even younger people, it increases their risk of falling by 9 times. And antipsychotic drugs that are what we call dopamine blockers, those antipsychotic drugs, even the newer ones, can also increase the risk of falling by 9 times. People that are on muscle relaxers like cyclobenzaprine or some sedatives like an antihistamine might cause for people who take Benadryl, for example, they can also be much more likely to fall. Some antidepressants, not just because of the sedating properties, but sometimes the antidepressants, just like the antipsychotics, do sometimes cause a slight increased risk in falls too. And then any blood pressure medicine or fluid pills, for example, a diuretic, which would draw some fluid out of the body, can result in an orthostatic blood pressure drop. And so blood pressure medicine, if it's working too well, it may also cause that patient to be at higher risk of falling. And then, as you might expect, higher dosages of opioids and some benzodiazepines like Valium or Xanax, those are not good for people who have balance difficulty and are at risk for falling. They did a survey of hip fracture patients, and nationwide, that survey showed that the average hip fracture patient was on 10 or more different medications. I did a survey of some of our patients on rehab about 3 years ago, and we actually had a time that those patients were taking 21 different medications on average. So I'll talk now about the other neurologic causes. Progressive supranuclear palsy is very similar to Parkinson's disease, but they also have slow eye movements and they have more voice and swallowing difficulty. The typical patient with progressive supranuclear palsy has a very severe postural instability. They tip over easily, and since they have trouble with focusing their eyes, looking up and looking down, those patients with progressive supranuclear palsy often have a history of falling down the stairs. So as I said, that's similar to Parkinson's disease, and I would definitely want a neurologist to make that diagnosis. Another Parkinson's type of disease is called multiple system atrophy. Those patients can present just like Parkinson's patients, but later on, or maybe at the beginning, they are noted to have autonomic nervous system failure. That means their blood pressure will drop when they stand, and they may have trouble with constipation, and they may have trouble with incontinence because of the autonomic nervous system failure. And that's called Scheidegger syndrome and multiple system atrophy. There's a less common condition, although I've seen just recently 2 patients who had corticobasal degeneration. These are, again, people who have Parkinson's type signs and symptoms, but they typically have some dystonia in their hands or fingers as well as in their feet. It sometimes is bilateral, but often it presents unilaterally. Then most people, I'm sure, are aware that some small strokes, you don't just have to have a large cerebellar stroke. If you have multiple strokes over the years, for example, people with diabetes, with high blood pressure, hypercholesterolemia, a lot of long-term diabetic patients can end up with multiple small strokes. And that's called a lacunar state because lacunes or lakes are noted in the brain because of those small multiple strokes. Then most people are aware that cerebellar ataxia is a common cause of the gait difficulties that we see, and that's in younger people that might have multiple sclerosis. There's also a disease called olivopontocerebellar degeneration that is a gradually progressive disorder, kind of like Parkinson's disease, but with cerebellar signs. And then, as I mentioned earlier, some people with diabetes can have some polyneuropathy, that is, the longest nerves in their body are affected, and so their feet may be numb and they may lose some ability to keep their balance because of that sensory loss. And then some diabetics or other polyneuropathy patients can have weakness too in their feet and ankles that does affect their balance as well. I won't spend too much time on this, but normal pressure hydrocephalus is also a disease that is a fluid accumulation in the brain, and that can cause 3 things: gait difficulties, incontinence, and dementia. And so again, these people need a neurologic workup, and we have to differentiate those from multiple system atrophy or multiple strokes. Another overlooked cause of some gait difficulty is a spinal cord problem. Some people have a chronic cervical or thoracic spine stenosis, and those people can have a little spastic gait with upgoing toes or positive Babinski signs, and they sometimes can have proprioceptive deficits because of the long tract sensory findings. And then one thing that is also overlooked sometimes is some people who fall infrequently, they may develop a subdural hematoma, and that subdural hematoma may be gradually progressive, and the patients just kind of gradually get a little bit worse over weeks or months. And so these are the people that we don't want to miss because those are treatable, and they need an imaging study, especially the more rapidly the onset is. Now, I'm not going to spend too much time about dizziness because this talk is not about vertigo. Dizziness is sometimes a very vague symptom, and so getting the history, you need to find out, is it triggered by movement? Is it just a feeling of lightheadedness? Are they lightheaded laying down? Are they lightheaded only when they're up and about? A lot of patients who have anxiety symptoms or anxiety attacks can have episodes of lightheadedness or wooziness or dizziness. And then, as I said, medication can cause that feeling of lightheadedness and balance difficulty too. But as I said, if the patient does complain of dizziness, what they sometimes can be actually talking about is they have balance difficulty and equilibrium problems, that is, they have a gait difficulty. And so again, the examination does help to differentiate those people who do have gait difficulties versus these other diagnoses. And as I said, many elderly patients are over-medicated with these medications, and hopefully that can be picked up by their primary care provider before they need to be referred. So as I said, any patients with a new onset of difficulty with their balance or equilibrium or frequent falling, they need a neurologic consultation if it's not obvious what's wrong. And falling is predictive. In other words, if the patient has had one or if a patient has more than one fall, they're going to have a higher risk, and the patient who's had multiple falls has a much higher risk of falling too. And obviously, avoiding the falls is much better than treatment. So let's get back to some of the other treatments now for what might be ailing these patients who fall. And those patients who are frail, as I said, it's not inevitable as we age. And so we recommend regular aerobic exercise. And you've heard this before, exercise is medicine. Primetime Alive at Mary Greeley has a number of exercise programs. Iowa State has Walk with Ease and exercise. The city of Ames has Parks and Rec programs that may not be going on right now, but hopefully they'll be going on again in the future. And Heartland Senior Services also has some good programs for people to stay active and exercise. The NIH website, which I've got here in my slides, is also a good place to go for advice for patients on exercise and other ways to avoid falling. And as I'll mention again, patients need physical therapy if they are at high risk of falling. So again, preventing falls, we want to have a patient go through an exercise program or physical therapy, review the medicines, get vision testing too, because people who have some visual impairment, they definitely are more likely to fall. And then we need to have a safer environment. As I said earlier, don't get up on a ladder if you're older and you're not very confident about your ability to keep your balance, because falling from a ladder is much worse than just simply falling from slipping on the ice. So at home, remove clutter, remove throat rugs, use grab bars and handrails. Make sure you have non-slip mats in the bathroom. Make sure at night you've got a night light or good lighting on. Make sure you use good footwear, especially in the wintertime. And then if you have icy or slippery surfaces, please make sure that those are treated. And so, as I said again, the more severe the gait and balance difficulty, the more the patient needs formal physical therapy. But hopefully those patients who are just starting to get frail, hopefully you can get them into an exercise program to avoid frailty. Now, there are many instruments that have been tried to detect the risk, but very few are very effective in detecting a high risk. There's a test called Timed Up and Go is one that may help detect risk. That's the same as what we do in neurology, though, for checking someone who has a gait disturbance. If they have trouble initiating their getting up from a chair or getting started from walking, that is a way to determine that they've got a gait disturbance. The fall risk assessment has been obviously the best way to determine a patient's risk. And as I said, the more falls that the patient's had, the more likely they're going to fall again. There are some functional balance tests that don't have a whole lot of value beyond the basic gait evaluations. As I said, the walking, the tandem walk, the Romberg, and checking for proprioception and checking for spasticity. Early intervention has definitely been shown in many, many studies with the use of some different exercise programs or multifactorial interventions have shown definite benefits in preventing falls. So as I said, physical therapy is very important. These type of training programs such as gait, balance, and functional training, it's better than resistance training, lifting weights, in other words, flexibility training, trying to stretch people out, or endurance training. It's important, though, that people dedicate at least 75 minutes a week if it's more intensive, or 150 minutes a week if it's a light or aerobic type of exercise program. There are other things that may help. Tai Chi, yoga, various dance therapies have been helpful, and that's where, if you want to get into some of these options, like I say at Iowa State or the City of Ames Parks and Recreation, those are good programs to reduce frailty. Vitamin D and calcium don't reduce falls, but they may reduce fracture risk. But they actually did a study of high dosage vitamin D, and people actually fell more frequently when they had too much vitamin D. So it's not that helpful for preventing falls. Cognitive behavioral therapy and social services are part of a multifactorial intervention, and those can be helpful too. If a patient is demented, as I said, there is a higher risk of them falling. So my summary is the history of falls and the fall risk assessment is a simple tool to detect the risk of another fall with injury. And then, as I emphasize, frailty is one of the biggest treatable causes that if we do treat the frailty, we can reduce the risk of falling with injuries. And then, as I said, don't overlook the possibility that medication, particularly polypharmacy, multiple meds, can cause a higher risk of falling. And then orthostatic blood pressure drops are a very common cause of falls. So again, get the blood pressure checked both sitting and standing. And then when people have a gait disorder, especially those that have had a relatively rapid decrease in their function, get them to neurology for a diagnosis and treatment, and also get them to the physical therapist who can give them a program, and hopefully the patients will continue with that exercise and the tips to help keep them from falling. Patients with Parkinson's disease do respond to the medicines. The best medicine for Parkinson's disease is levodopa, but unfortunately late in the course of the disease, the levodopa medication doesn't help the gait or the postural instability as much as we would like it to be. So there really isn't any one medicine that is going to help prevent people from falling, but treating their condition is definitely important. And as I said, I do think physical therapy is definitely needed for most of these people who have problems. And Tim, I left some time for questions. I actually have a little bit of an audience here, so I can take some questions too.
Anyone who has questions, please type them into the box and I will ask them.
Okay, I actually have a person in the audience. He's going to ask the question. I'll repeat it for the...
My mother, who has deceased, had a problem for a short time of falling backwards, and she saw you years ago, and you diagnosed PLS, peripheral sclerosis or something. Is there some specific reason why they tend to fall backwards?
Yeah, the question from a person in the audience here is that there was a person who fell backwards, and the diagnosis at that time was primary lateral sclerosis, that's PLS. And so that is, again, a spastic type of gait, People can fall over easily. Could be forward, could be backwards. There's not too much to make of whether people fall forward or backward. As I said, progressive supranuclear palsy, that's also called PSP. Like I say, these people are a little Parkinsonian, but their ability to keep their balance is really severely affected. So they tip over very, very easily. So again, the only treatment for that would be get them some physical therapy, have them use a walker. But even some of these PSP patients and severe Parkinsonian patients, unfortunately, when they've had the disease for many years, the medication and the cane or the walker is not enough. And so unfortunately, some patients can't be relied upon to walk on their own without someone helping them. But we do want to keep them walking just with someone helping them. And Tim, did we have any other questions from the other?
Questions have come in.
Okay, well, anybody can email me if you have some other questions. And like I say, as a neurologist, I'm more than happy to see people. If you remember at the beginning of the slideshow, Dr. Kitchell doesn't have any conflict of interest, but if more people fall, I'm actually going to be busier and see more people on the rehab program. So I'm just like a dentist, I'm trying to prevent things from happening. I hope that people will take the advice and avoid frailty and do those things to keep from falling. And so good luck to everybody, and I will hopefully see more people getting into exercise programs as time goes on here, and hopefully the COVID situation will be over. Thanks then.